Hi guys, it's Jordan and Aubrey with Education, and we are here to film a Tip Tuesday on chest tubes. So when your doctor tells you that they are going to insert a chest tube at the bedside, we're going to show you all the necessary supplies and then how to manage. So first things first, you'll need to actually grab a chest tube. They come in different sizes, and it says right here on the tube what size you will want to grab. They range all different sizes, so just make sure you're looking at the size. You'll also need to grab an atrium. It comes in a package just like this. This one is a single collection. We also have a dual collection. The only difference is the number of pigtails that come off the top of it. If you're using a single collection, that's probably going to be the most common. If you happen to grab a dual, it's no big deal. Just clamp off the pigtail that you're not using. You will also need Xeroform or Vaseline gauze. Either one work. You will need tape. You will need transparent tape to wrap around the tube itself. And you will need 4x4s and Hibiclins, which we did not grab. So once you've got your atrium, it's going to come out in a blue wrapper just like this. Typically as nurses, we think that blue means sterile. In this case, it does not. This is going to be sitting on the floor. It is not sterile. It is clean, so keep it clean. But you're just going to pull it out of the box and discard what you don't need. You will also need your suction set up, your regulator, one suction tubing, and one canister. So your regulator needs to be on continuous suction always, never intermittent, either regular or continuous, and it needs to be set at least 80 at the wall. Even though this isn't what regulates your suction, it needs to be set at that to make sure there's enough suction to work in the atrium. So, in case you forget what we're talking about today, on the back is step-by-step instructions that also tell you everything we're about to do. So what you're going to do is you're going to grab this little thing of water right back here. It's attached to the back. And you're going to put it in this little blue port. Blue equals blue. You're going to put water into the blue port. You will put the entire thing, no more, no less. This is exactly what you need. It will fill up to the 2 centimeter line here. That's just plenty of water. You should never have to add water. This is a closed system, so you'll never have to add, you'll never have to take away. Once you've got your water in there, you're going to hook up your suction. And your suction goes right here in the exact same port. It says at the top if you happen to forget. This does have a little stand here at the bottom so that you can stand it up on the floor. Once you have everything set up and your suction is appropriate, you're going to check this little bevel here. This bevel should come to the delta line. That means that everything is working correctly with your suction. If that doesn't happen, check your regulator. This right here is what actually regulates the suction. It comes out of the box at -20. If the doctor wants something different, then he will put that in his order. So be sure and look at that. The way to change that is there's a little dial right here on the side. You'll just dial up and down what you want your suction to be set up. Next, we're gonna wait on the provider to actually put the tube in. And your job is to hold this. This is the part that will stay clean because this part does go not into the patient's body, but it connects to what does go in the patient's body. So we don't want to get this dirty in any way, shape, or form. Once the provider has inserted the chest tube, you will hand them this piece. They will then tape around to connect this piece to the tube that's in the patient's body. This is the part that needs to use clear tape, so we want to make sure we can see through it. So typically we tape up one side and long ways up the other side so we can still see in the middle to make sure there's no blood clots. The provider will also typically put your first dressing on for you. After that, chest tube dressings are changed to daily and PRN for soiling. We've had a lot of confusion over chest tube dressings, but here at Christus, our policy is to change them daily. If your atrium happens to tip over, used to be that we would change the entire atrium out. That's not the case anymore. Per manufacturer guidelines, all you have to do is tilt the fluid back over into the original compartment. You're not going to get it all, so make sure you're just marking what's left over so that's not counted in subsequent outputs. Output is documented every 4 hours if you're on a med-surg unit, every hour if you're in the ICU or IMC. Just make sure you look at your orders to see what the provider has ordered, how much they want their output documented. Make sure you're marking on the chest tube itself what the output is at least once a shift so that the provider can come in and look at it. And you will have to document on the assessment itself once a shift. All of that is done under the eyes and nose flow sheet. Once you put the chest tube in on the avatar, your eye and nose flow sheet with chest tube will automatically populate. That's where you'll document your output and document your assessment on the chest tube itself. So let's talk about air leaks. An occasional bubble in this chamber is okay. It's normal and it's expected, and that's what we like to see. When we have continuous bubbling, that's when we're suspecting an air leak. So the first thing you want to do if you suspect an air leak is check all your connections. Start with the patient. You want to make sure that this part of the tube, that you don't see any of these little holes. If you see any of these little holes, obviously your tube's about to come out. There's not much left in there. So we want to make sure we don't see any of that. This also has centimeter markings on it, so you can check to make sure that that hasn't moved. These are typically sutured into place, but they do come out. They're not very big. So check your centimeter markings, especially making sure that we don't see any holes. If we do see holes, secure it the best you can. Call your provider so that they can come and put it back in. If your tube falls out, this is a medical emergency. You need to tape up a 3-way dressing, which is your gauze, your Vaseline gauze, your 4x4s, and tape on 3 sides and call your provider ASAP. That is an emergency. We need to handle it as such. So if everything up here looks fine in the patient, you're gonna move down to your next connection, which is right here. Make sure that there's no leak here. Everything is secure and in place. If everything is good here, the only other place you could have an air leak is right here at your connection. This just connects in and out to change the atrium. And if it doesn't click into place, there could be a leak there. If you've troubleshooted everything and everything looks good, you want to contact your provider and let them know that there is a possible air leak, and let them go from there. They will typically order a chest x-ray to look at how big the leak is. If it's big enough, they might choose to put in a second tube, in which case you would need a whole new setup, or a dual atrium. Or they might choose to let it resolve on its own, in which case you would just document that the provider is aware, but that there is an air leak present. You should see titling. This little blue ball should rise and fall with inspiration. That is completely normal. And then when it comes time to actually change your atrium out, if this fills up all the way, you've got to change it for a new one. Like I said up here, you just disconnect. So have your second setup all ready to go. This is going to be the one and only time that you will clamp your chest tube. You will clamp right here with the blue piece. You will depress this plastic piece and pull it out. Have your new one set up and ready to go. Push your tube back in there, and please make sure you unclamp. This is a big deal. We don't want to leave our chest tubes clamped. We should also never be pulling these patients off of suction unless we have a provider order. The only time that these patients should come off of suction is to travel to MRI, CT, something along those lines. So if your patient needs to go to the bathroom, they have the length of their suction tubing to be able to do so. If they can't reach the bathroom, get them a bedside commode, give them a bedpan, but they cannot come off of suction and go walk with therapy or get up and walk around the halls, because they have to stay on the suction unless the provider says otherwise. So make sure you're checking with your provider to find out what it is that they want to do for the patient before just pulling them off of suction. When it comes time to start weaning the patient off of their chest tube, the provider's gonna order something called water seal. All that means is we're pulling them off of suction. This chest tube is now set to water seal. This means that we are trying to see how the patient tolerates it so that we can hopefully pull the tube out. Once the tube is pulled, once we have DC'd the chest tube completely, that initial dressing will stay in place for 48 to 72 hours. After that, we will continue to change until our scab is healed.
So Jordan, if we switch the patient over to water seal, should we leave our suction canister in the room in case we want to reattach them?
You should not, because somebody might come in behind you and think that they're supposed to be on suction and go ahead and stick them back on. So go ahead and throw your suction tubing and canister away, turn your suction off, just get rid of all the evidence that they were on suction and keep them on water seal.
Okay. If we are transporting a patient, do we need to clamp their line when we take it off a suction?
Do not ever clamp the line unless you are changing the atrium itself.
And when we transport, is there a way to attach it to the bed to keep it from tipping over?
There is. You've got handles right here to attach to the bed so that you have ease of transport.
If we have the atrium up above the level of the chest, will it drain?
It will not. Your atrium needs to be sitting on the floor or below the level of the heart.
Awesome. Thank you so much.
Bye, guys.